problems related to visualization, and I'd like to stress here that good visualization is the key to a controlled operative procedure, and any factor that limits visualization can seriously affect the surgical outcome. So when you start operating, if you come to a situation that your visualization is getting hampered, it's very much worth its while to spend 2 or 5 minutes to try and set that thing right, rather than saying that now it's okay, I'm towards the end or something like that. Because what happens is, if you're not seeing clearly whatever instruments you're introducing inside, and especially when in a vitreous surgery situation, you can really be in a lot of trouble. Now, what are the types of problems that you encounter when you in relation to visualization? One of them is, now this is a very well done ROP surgery. You can see this is a very small baby, hardly about 1.8 kgs. Now here, these kind of situations, what happens is that if you see the size of the biome lens, the objective lens, it is as small, it is around 19 millimeters or 20 millimeters. The size of the cornea of the patient is something like 9 millimeters. So basically, if you see, I have shown the line diagram there. Do we have a... So basically, this is the way your instruments are going in. Even if they go almost abutting the lens, it's very difficult to come into this area. So basically what happens is, to try and move your instruments inwards is very difficult because of the nature of the size of the eye, as well as the fact that your lens size. Now, one of the solutions to that is Oculus also has what is known as a mini wide field lens, which is only 12 millimeters as compared to the 19 to 20 millimeters one. Of course, the trade-off is that the degree which you are seeing is 70 degrees. But then the 70-degree thing is not so much of a problem, is because you can drive the eye a little bit. But this is something which I think one needs to bear in mind, that this sort of thing is available. Now, the other issue is related to corneal transparency, and the most commonest problem you encounter is corneal edema, especially in patients who come with a dropped nucleus, because that's definitely one of the issues there. And what I have noticed over the years is, the minute you decompress the eye, in the sense that you make your sclerotomy openings and you start cutting the anterior vitreous, most of the times as the pressure comes down, the edema clears quite a bit. So don't take a decision on the edema right at the beginning of surgery. Just wait for about 2 to 3 minutes. Many times an edema which looks a little threatening initially, it does tend to settle down. If it doesn't happen, you have an option of 10% 100% glycerol, which you can just instill as drops. Or what we do most commonly, at least that is the thing that I do as a matter of choice, is to scrape off the epithelium. Now that's something I don't like to do if any of the cornea colleagues are standing around, because they really don't like the kind of disrespect that is shown. But it works amazingly. The only thing is, after you scrape off the epithelium, you have to keep putting the saline on the cornea more often. I can see most of the people nodding their heads, because these are things which we actually have experienced in the OT. And as compared to an epithelialized cornea, once you have stripped the epithelium off, you have to keep putting the saline more regularly, so that it doesn't get dry. Now, the other issue is, you have a corneal opacity. Now, sometimes what happens is, the corneal opacity lands up affecting the visualization more than you expected. Now, one thing what happens is, when we are using nowadays these wide field non-contact systems, these corneal opacities, they interfere more many times than when we were using Lander's lenses, which sat on the cornea, and thereby the anterior most place where the maximum refraction took place was the surface of the Lander's lens. But most of the times the solution to this is, you try and have a larger pupil, and you find the gap around the opacity, and with a little bit of driving the eye, you can go through it. What is really dangerous, and this is something which I want everybody to really, probably most have had this experience, patients with RK, see what happens is, those incisions are almost 98% thick through the cornea, and some of them have had micro perforations as well. Now, when you basically start the vitrectomy, gradually from there it starts hydrating. I mean, that's a better case scenario. I have had one patient where the actual thing opened up and we had to suture the cornea. But the fact is that there are cases definitely where it starts hydrating. So for that, one thing I definitely suggest is that when you're doing a patient with with RK, you better have a lower bottle height, or if you're having a system where you can set the pressure, inflow pressure, it should be at a lower level. Now, this is another very notorious thing. See, if you see, this is a beaker, you need very little amount of contamination into it to make it turbid. And what happens is, you can have a situation that either pigment from the iris gets released into the anterior chamber. That usually happens when, when you have been indenting and things like that. Those are times when you have this type of pigment being released. And the other situation is you may have blood sometimes being released from the angle in an hypotenuse eye, and it actually sort of just a little bit of it is there. It's not even a drop of it, but what actually happens is it becomes very, very turbid what you're seeing. And the best way to do it is you can displace it from the pupillary area with a viscoelastic. And of course, I'd like to stress here that at the end of the surgery, you must make it a point to wash out the viscoelastic, because we as vitreoretina surgeons are not used to putting it in and out. So if you leave it in, then you're going to have issues related to pressure and things like that. Then comes the issue of inadequate pupillary size. Now, when we were residents, when we were training, at that point in time, we were doing the surgeries were being done mainly with the contact lenses, and there the small size pupil meant disaster. However, with today's wide angle non-contact systems, a smaller, I mean, you can do a reasonably good vitrectomy with even a 4 mm pupil, which we couldn't have thought earlier. But here what happens is, there are still indications where we use the Lander's lens. A lot of people, I don't know, at least I, whenever I'm doing an ILM peeling or I'm doing any macular work, I prefer to use a Lander's lens at that point in the surgery. And especially when it is a combined procedure where a phaco has been done first and then you are planning this next part of it, what can happen is, you may have a situation that the pupil has become small, and that can be quite a nuisance. Especially this happens in pseudophakic patients, in patients with synechiae hypotony. We have options of iris hooks, and sometimes what I also do is do a very small sphincterotomy with the cutter, and that's sufficient to open up. And that sphincterotomy, if it's small, you don't really get a very misshapen pupil at the end of it when you see the patient after 10 to 15 days. As far as the intraoperative cataract is concerned, I think Dr. Bawankule has actually touched on it, but I'd just like to say this, that there are two types. One is where there's a breach, one where there's no breach. If there's no breach, it's usually because of the air fluid exchange, because of the drying of the lens from behind, and especially, or a direct jet of fluid. If your cannula is tilted little forward, you have a patient with an early PSC, so there's a little bit of weakening of the capsule, probably a little bit of that goes in through there. So one of the things is, if you feel that there are certain issues with the lens, you could use a BSS plus for those kind of patients. And as Dr. Bawankule said, that if it's a small breach, you just continue with your surgery and then decide. If it's a large one, then you would have to go and do a lensectomy at that point. One small tip, just a small tip, that if you have a very small breach and you don't want to at that point in time do a lensectomy, because what's going to happen is, if you're putting in, you can have an option of putting in silicone oil. And believe me, these patients, they develop a cataract very slowly in that situation. Many times at the you can pull on for another 2 to 3 months, at which time you're going to remove the oil. So you remove the oil, remove the cataract, and put in an intraocular lens. Now, related to the lens capsule, just a few things. There is capsular phimosis. This can be addressed in its own way. The RF capsulotomy is very useful for this if you have it with your phaco machine. If there's a capsulotomy, you can make an opening if there's a thick capsule like this. But if you have a capsular or zonular dehiscence, I think these are cases where I follow a very simple norm, that if I can drain the fluid just doing a fluid-fluid exchange, and if I can apply my cryo or laser prior to doing the fluid air exchange, many times I prefer that, because what happens in these situations is, when you do a fluid air exchange, you have some of the gas coming into the front of the eye, and that definitely affects your visualization. So one other trick is that when you do a fluid air exchange in these kind of situations, do it with a low pressure. Do it at around 25-30 millimeters of mercury rather than doing it at 50. Now I'm not going into this because I think this is going to be discussed by the others who are present. But this is another thing which happens, that during fluid air exchange, you may have a situation that you actually get this kind of misting on the lens, which happens when you are in the shower, on the same way that happens on the. So you do the same thing there. What they are showing is doing it with a finger. Here what I normally do is just use the light pipe and I just wipe once in a while. But one of the other things described is to just put a little bit of visco on the lens, but I am not very keen on that, because I think that would affect the visualization to an extent, So the easiest thing to do is just keep wiping. Now, as far as these intraoperative viewing systems is concerned, you are aware with these systems we had limited field, we needed larger pupil. The other thing is, you need to keep having good assistance, because the position can shift a little bit, and blood in the interface. Sometimes you realize why you are not seeing well, and then you realize just a little bit of blood by capillary action has gone in. So you make your assistant pick up the lens, you just flush it and then you put it back again. So that works well in that situation. Just the last thing that I'd like to mention here is with the wide angle systems, if you are having a surgical maneuver wherein you are doing the vitreal, I give you a classical example of this. There is an IOL on the retina. You have done a vitrectomy, you have gone